This week on Living with FASD, Candid Conversations with Patti Kasper, we have Dr. Sarah Mattson joining us. Dr. Mattson is a fetal alcohol spectrum disorders researcher with San Diego State University in Southern California. They are doing some marvelous work both with screening tools and possible intervention measurements. So she's just going to tell us all about the exciting work that they're doing down there. This podcast is for those who are living with the effects of prenatal alcohol exposure, their family and loved ones, and anyone else wanting to learn more about fetal alcohol spectrum disorder. So thank you for tuning in this week. I hope you enjoy this candid conversation. Sarah, welcome to the show.
Thank you, Patti. I'm really happy to be here.
Yeah. So what brought your interest to this specialty?
That's a great question. So I've been actually working in the area of FASD since before it was called FASD. When I was an undergraduate student in upstate New York, I started working in the research laboratory of Dr. Ed Riley as a sophomore in college. And at the time, he was working on animal models of prenatal alcohol exposure. At the time, I really found the idea of research interesting and the idea of understanding prenatal alcohol exposure. It wasn't really something that I knew anything about before then. I learned about it in class and I started working in the lab. Ed Riley ultimately took a job across the country at San Diego State. And so I came to San Diego State as a graduate student to continue that work. And so at the time, I was a 22-year-old kid.
Mhm.
And I came to San Diego across the country. And got to meet Ken Jones and got to meet some other, and work with some other really incredible people here in San Diego. And together we developed a research program where I was being trained in neuropsychology. And so we leveraged that to start working with Dr. Jones on understanding the neuropsychological features of people who were living with FASD.
Mm-hmm. So from what I've been able to tell, and certainly it happened with me, that once you learn about FASD, you're changed. What was the hook that got you to go all the way across country?
Nobody's ever asked me that. I think it was, I really loved research and I became passionate about the topic. I thought I couldn't believe that we didn't know very much about it. And I just, I wanted to learn more and contribute to the field. So, I've been doing it ever since. I feel very fortunate that I'm working in the area that I went to school to work in.
Yeah.
So I feel really lucky.
That doesn't happen to many of us.
No, it doesn't. So I feel like it's a much more unusual occurrence.
That was what, 10, 15, 20 years ago
and I moved to San Diego to be a graduate student in 1988.
Okay.
So many, many years ago.
Yeah. So we probably graduated about the same time. I got my first master's in 1990.
Yep. I got my PhD in 94.
Okay. There you go. I haven't gone that far. So that's really something that you've been in this field for nearly 25 years now. What are you most excited, the changes that you've seen or the developments, the new knowledge? What are you most excited about what has come to the forefront in this 25 years?
There's been a lot of changes in the field. And I think, when I look back, there are some things that I can't believe we even thought at the time. Like, for example, that if you were a person whose mother drank in pregnancy, but you didn't have the facial features of that are required for an FAS diagnosis, that you were spared and that we didn't really have to worry. right?
Mhm.
And what we know, based in part on work that we did in the early 90s, that the neuropsychological features of kids who have an FASD are they occur whether or not you have the facial dysmorphology. And so, as a neuropsychologist, of course, I'm biased. I feel like, understanding the neuropsychology is really important, and understanding how the exposure affects daily living is really important. But everyone, at least everyone in our field, understands that to be true, but it
Yeah,
wasn't always the
yeah.
way.
But the general public has not caught up with that knowledge yet.
That's
And
true.
one of my snappy comebacks is, well, congratulations, then you know which 5 days there was some exposure to alcohol.
Right.
Because that's basically all the facial features tell you.
Hmm.
What are some of the other things that is like, I can't believe we thought that?
Well, so I think this was before my time even, that we thought that the fetus was protected, right? Like you might have seen these cartoons of a fetus in this little like Sputnik kind of thing where they were protected from the outside environment, meaning, the uterus and the
Mhm.
and all the exposures that could happen. And of course we know that that's not true. And I do think that the general population understands that now, but we didn't always think that. So that's a huge thing. There's still a lot of people who don't know very much about FASD.
Exactly.
I'd like to say FASD is the most common neurodevelopmental disorder that nobody knows anything about, right?
Exactly.
So I try to, talk to as many people as possible. I teach a large class at San Diego State and I tell them all, about FASD. It's just 500 people at a time. But
It's a big class.
yeah, yeah. So I feel like we still have a long way to go
Yeah.
to sort of spread the word about
Yeah.
FASD. But I think things that have improved, I think, or have changed, I guess, is we understand more about how FASD presents. It's different in some ways than other developmental conditions. It does have some common elements, but it also has some unique elements.
Mhm.
And I think we're learning the recent work looking at interventions in FASD is exciting. Of course, my focus is on the screening of FASD, trying to improve how we can identify people who are affected. But yeah, there's been a huge amount of change I think it's almost 40 years actually since I've been working in this area. So a lot has changed, but we still have a lot more to do.
Yeah.
That's amazing. I mean, I think if I had looked forward 40 years and said we would still be doing this,
You would be as surprised then as now looking back,
right?
right? And you were aging very gracefully because I would not have said you've been working for almost 40 years.
Well, to be fair, I was very young when I started.
Yeah. Yeah, I,
But
I
yeah,
was too.
thank you.
I was 16 when I started college.
Oh,
So
wow.
yeah, the yuppie version of running away from home. But I I totally get the obsessiveness of talking about it. Once it becomes your passion. When I was having my surgery before they put me under, there's like, oh, so what do you do? Game
How
on.
much
Here's
time do you
another
have?
audience. So I was telling them all about the podcast until they said, we're going to put you to sleep now. Okay. Anyhow, what are some of the other things that maybe get you feeling frustrated that the general public doesn't yet know or understand? Or maybe another way of phrasing that, what are some of the things that we really need to dig into?
Yeah. I think we touched on this briefly, is there are still a lot of people who don't recognize the risk of drinking during pregnancy. And I mean, it's the most basic at our core. This is the most important thing for people to understand
Yeah.
that drinking during pregnancy carries risk. And you've probably had this experience, but you've talked to people and they'll say, well, my mother drank during pregnancy, or I drank during pregnancy, or my doctor said, and we know that that's true. All of those things are
Yes.
true.
And
And
I'm fine, or she's fine, or he's fine.
right, right. And
Therefore, I
so,
can keep doing it.
yeah,
Yeah.
right, right. And so I think that is something that we've been doing, we work at it. All of the people in the FASD community work at it. FASD United is an incredible organization. They work at it, and just, getting the increasing the public awareness
Yeah.
of the risk of drinking in pregnancy is just continues to be critical. It's
Mhm.
not like everyone knows that it's a problem, and we're working to try to help people, which we are trying to do, but we're still even have to prove ourselves
Yeah.
to say that alcohol is a teratogen, and it's something that people need to know. That fact is something people need to know about, and it's not just the public. It is also professionals.
Yeah.
And so that has been something that's been increasingly or just continuously frustrating for me.
Yeah. Yeah. And there's so, which is kind of the shocking and very disappointing aspect, is that there are medical professionals who are still not clear on the
Mhm.
reality that there's no safe type, time, or amount of alcohol exposure that's safe. I know some professionals think, well, one glass of wine versus chronic maternal stress, which is very damaging to the
Mhm.
baby, right? It kind of breaks the thermostat for the
Mhm.
baby's developing stress modulation. You know, broken thermostats aren't good.
Mhm.
And so they'll mistakenly give the advice of, oh, a glass of wine with dinner, that's okay. It'll keep the stress levels down. But there's a huge price tag that comes with that. A huge price tag. So I'm one of the offspring of daily glass of wine while cooking
Mhm.
dinner.
Mhm.
And and that just kind of goes to show the wide variety of effects, because that's another misbelief, is that it means low intelligence if you have fetal alcohol, if you're on the spectrum.
Mhm.
And here I am with 3 master's degrees.
Mhm.
So it's really disappointing that well-intentioned bad advice is
Mhm.
still being given.
Absolutely. Yeah, I agree with that. And I think, like I said, there's still a lot of education that needs to be
Mhm.
done. But you were talking a little bit about the spectrum, and I think that's an important thing to talk about, right? That there's a huge range, right? So, and we touched on it a little bit earlier, that if you didn't have the facial dysmorphology related FAS, that you were spared. And we now know that there's this spectrum of effect, right? And some people have facial dysmorphology and really critical cognitive and behavioral impairments, and some people have less effect. And there's a range, and that's why we now call it the fetal alcohol spectrum disorder, right?
Yeah.
So, or disorders. So, I think that's a really important thing that's changed over the years. That we recognize that people are affected differently. I mean, it sounds sort of obvious to say, right, that everybody is different, and that there's a huge range that we see in the population of people who are living with FASD.
One thing that I often do when I'm training people or coaching with people is to bring out the fact that most people think of a linear spectrum, right, with high and low functioning on either end.
Mm.
But in reality, we're three-dimensional people. The effects are multidimensional as well. So it's, so that people quit thinking in a, linearly.
Mm-hmm.
You
Mm-hmm.
know, when you
Yeah.
have linear effects, it's more likely that you're going to find clear and concise patterns, and you will find more people when you do the psychological testing. But
Mm-hmm.
because there's so many different things that factor into how any individual is affected, it it's impossible.
Exactly, exactly. And
Yeah.
there's a lot we don't know, in terms of risk and protective factors that
Mhm.
genetics, for example, could be one that some people with specific genetic makeup are more susceptible to the effects of alcohol and some people are protected. And we don't know the answers to that yet, but I think we will, hopefully. But there's other factors too, of course, things like nutrition and that are going to be beneficial. But yeah, it's really important to understand those individual risk factors.
Yeah. So speaking of diagnosis,
Hmm.
you guys you're part of CFAST, right?
Hmm.
And you guys have come up with a screening tool that, is generating a lot of excitement. So tell us a little bit about that.
Sure. So the Collaborative Initiative on Fetal Alcohol Spectrum Disorders, or CFAS, is a group of investigators around the country and around the world who are all invested in understanding FASD. And one of the areas that we focus on is screening and diagnosis. And so, and that's part of where I fit into CFAS. I'm really interested in trying to reduce the diagnostic bottleneck, I guess, and improve access to screening. And so you probably know, to get in to see a clinician who's an expert in FASD is challenging. There are not very many specialty clinics. The wait times are very, very long. And there was a study out of Canada that said the wait times were over 4 years in some cases. I
I
mean,
believe
which
it.
is really unimaginable and unacceptable. And so, but we also know that there just aren't enough specialists, right? And that gets back to the previous point about, professionals not necessarily appreciating the diagnosis. And so we need more people with more access. And so we set out to develop a screening tool. And we have another screening tool called the FASD tree, which we can talk about if you're interested. But this
Sure.
one, the second one, is Brain Online, which is a cognitive screening tool. And it's an online test that anyone can log in to the website. And it's really, you don't even have to log in, you just click and you take the test. And it depends on the person, takes anywhere from 30 minutes to 60 minutes. It requires internet access. But it's done at home. And
Okay.
we designed it to be useful across the age range, starting at age 5. So
Wow.
5-year-olds all the way up through adults can take the test.
So younger children, would parents take it answering on the children's behalf?
Actually, that's a great question. So the way it works is the first thing that if for a child, the parent logs or clicks the link and starts the process, they answer a few questions about the child, like how old they are, whether they're a boy or girl, what race they are, things that will be important for us to understand are the data that we're collecting. And then they answer a brief set of screening questions on the behavior of their child. And then they help their child get set up to take the test themselves. So the child actually takes the test.
Okay.
The parent can help them get started, but they're not supposed to do the test for them because we want to understand, how the child performs.
Yeah.
If an adult is taking the test, the process is the same, except that we ask at the beginning, how old are you? And it's the same test, but for the adult, it asks about you instead of about your child.
Yeah.
And the adult answers the same screening questions, the same behavioral screening questions, and then takes the test themselves. The benefits of Brain Online are that anybody can access it. Right now, it's free.
That was my next question.
Yeah, well, we're funded by NIAAA, part of the National Institutes of Health, to perform these studies. And so we do ask about prenatal alcohol exposure in the screening questions. So part of our study is to determine whether we can use Brain Online in this way, right?
Okay.
So that somebody and people without prenatal alcohol exposure can also take the test. In fact, we encourage it because we need to have, people to compare,
Mhm.
right? And so right now we're funded to do the work by NIAAA, and that may not always be true. We may
Yeah.
transition to some sort of fee-based program, but for now, or donations, but for now it's funded by our research. We
Okay.
also use the Brain Online within our local research project and in the same way. But the benefits are that it's available. It's accessible, right? If you have an internet connected computer, you can take the test.
People could even do it on their phones.
They cannot do it on their phone. So thank you
Okay.
for asking that. You can do it on a tablet with a
Okay.
keyboard or a laptop or a desktop computer. But right now you can't do it on your phone because the phone is too small and it requires a bigger screen. That
Okay.
actually was our original goal, and we're still hoping to figure out a way to get there, but we don't have the real estate on phones right now. So
Okay.
but it's available. And we also know that, as I mentioned, the wait lists for FASD diagnostics are very long. And so one possible benefit to Brain Online is that clinicians could ask their patients to take Brain Online while they're waiting.
Okay.
And use that information to help guide their diagnosis. So if a person takes Brain Online and performs in a way that is consistent with an FASD, then the clinician I'm not saying they will, they might, try to evaluate that person in a FASD related way, or maybe move them to the front of the list or up the list. Or
So,
if they don't show features, they might then say, we need to, move you in a different path.
yeah. So a clinician at a community mental health agency would be able to then factor the information in and maybe diagnose NDPAE.
That's a great question, actually. We have not yet used Brain Online in the NDPAE diagnosis.
Okay.
We have done actually a couple studies looking at NDPAE diagnosis, and that's one of the things on our list is to see if we can use, because NDPAE has very specific diagnostic criteria, and we would have to look at Brain Online to see if our tests fit into those specific criteria. But we also can do the same thing with ARND.
Okay.
And so those are definitely some future things that we're going to be looking at. Right now, we're looking at more generally, and we have a paper that's under review right now, looking at how good is Brain Online in identifying people with FASD, and we found that it identifies over 80% of the sample that we tested.
That's
And so
amazing.
yeah, thanks. So we're hoping to replicate that in additional studies, but I think the question about can we use it for NDPAE or can we use it for ARND or FAS, those
Yeah.
are really important.
So I'm just trying to make it clear, at least in my own mind,
Mhm.
how that process works. If you have a local clinician who's not qualified to diagnose FASD,
Mhm.
but at least is aware of it enough to refer someone to do this, what would they do with the findings? But even before that, say, Joe Schmo decides, oh, I heard about this, let me do it. They enroll, go through the process. Then what?
So right now, the way it works, if you take Brain Online through the public link, and we ask you, are you interested in getting feedback? And if you say yes, we will provide you with a summary of the results, how you did on the test. And
Mhm.
then you can take that information to your clinician, who would then say, this is really great information. Let's see what we can do about that in the ideal situation, right? And so I think it's important to note that Brain Online is not going to give you a diagnosis. It's
Okay.
not it shouldn't be used to give a diagnosis, but it can be used as a piece of the diagnostic process, right?
Okay.
So a
Which is
psychologist
why it's called a screening tool.
exactly, exactly. So, a person, like you said, a clinician who's not an expert in FASD could have a patient take Brain Online and then, use that information as part of the diagnosis, or use that information to say, we need to get you to an FASD clinic, right? This is evidence that, helps me push you in that, or helps me help you get to that diagnostic clinic.
I'd love to put the link in the show notes
Okay.
so that people who are interested, whether they are questioning themselves if they have FASD, or if they're questioning a family member, would have it, that they can pass on that information.
Yeah, I'm happy to send that link to you.
That would be wonderful. So what's that other project you had mentioned?
So the first screening tool that we developed was called the FASD tree. And the FASD tree, again, it is part of my goal to improve the diagnostic process, but it's a different type of tool, and it's not for use by the public. A clinician could use it. So as you know, the diagnosis of FASD requires a physical exam with an expert, and then cognitive and behavioral assessment. There aren't very many experts who can do the physical exam. And so my colleagues, Dr. Ken Jones and Dr. Miguel Del Campo, have been really interested in whether or not you can train other providers to do the physical measurements that are required for a diagnosis. And so they have a number of papers on that. And what I really wanted to do was to come up with 4 questions that could be used as a screening, as the start of a screening for FASD. And it started that way because I went to the doctor one day and just for, regular checkup, and the doctor asked me a few questions. I don't even remember what the questions were, like, how old are you? Do you have a family history of breast cancer? I forget I don't know the questions, but it was very, very few questions. And he took those questions and he plugged them into this little calculator. I don't think it was a phone. It could have been a phone, but it was a long time ago. And he said, well, you don't have any risk for breast cancer. And I said, well, that's wonderful. Thank you. But I was really excited about this idea that he just asked me these few questions, and was able to rule out that possibility. Hopefully that's a true memory, but that's how I remember it. And it set me down this path of coming up with 4 questions that we could use for FASD. And I have not been able to come up with 4 questions, but I have been able to come up with 4 types of questions. And that's how the FASD tree came about. So we collect a few physical measurements. We use 2 parent questionnaires that are commonly used, and we ask for an IQ score. And we take the information from those 4 measures, and they're entered into a website. There's an algorithm that runs, and it comes up with whether we think that person is affected in a way that's consistent with prenatal alcohol exposure. And it comes up with 2 output scores. One is what we call FASD positive or FASD negative, and a risk score. And the risk score ranges from 0 to 5, and the higher the score, the higher the risk of prenatal alcohol exposure. And that we've looked at that study, that tool in a number of studies. We show that it's highly effective in identifying prenatal alcohol exposure. Over 80%, again, of people who have a history of prenatal alcohol exposure in our studies are picked up by the tree. And we also know that the outcome of the tree, whether you're FASD positive or FASD negative, is related to neuropsychological testing. The FASD tree doesn't have any cognitive score, any testing related to it. It does collect or does ask for an IQ score. It's not actually part of the algorithm, but it doesn't involve any neuropsychological testing. And that's what led us to Brain Online, right?
Okay.
So we developed Brain Online because we wanted to test cognition specifically. So
Yeah.
in the future, it would be ideal if we could bring our two tools together, right? So if we could bring the FASD tree and Brain Online together, both of them alone identify more than 80% of affected individuals. So we don't know how they'll do if we put them together.
So I'm very curious about the use factoring in the IQ information,
Hmm.
because so many of us are impacted with our adaptive functioning as
Mm-hmm.
opposed to the intellectual functioning. Is there, what about concern that it's missing a lot of people
Mm-hmm.
who are, not doing very well adaptively, even
Mm-hmm.
even though they do well on paper and pen tests?
Yeah, that is a great question. I'm laughing inside because I, for a long time, have said that we can't use IQ as part of the diagnostic process.
Mhm.
It is, to be fair, it can be an important indicator in
Mhm.
people who have an IQ score that's below average. But just using IQ alone misses the vast majority of people who are affected by an FASD.
Mhm.
So the FASD tree does record an IQ score. We just ask for it. We don't do any testing. But we don't use it. It was specifically not part of the algorithm because of my belief
Mhm.
about the IQ score. We do know that there definitely are people on the FASD spectrum who have lower than average IQ scores, but there are also lots of people on the FASD spectrum who don't.
Right.
And you mentioned adaptive functioning. Adaptive functioning is definitely an area that we see as affected in our research across the board, regardless of IQ score, in people who have an FASD. The FASD tree incorporates adaptive functioning in the algorithm, but not IQ.
Mhm. Okay.
Um, and the Brain Online doesn't have an IQ score specifically, but it does assess neuropsychological functioning, which can be correlated with IQ. So that's why, we need to bring these two tools together.
Yeah.
But I
Let
do
me
think it's
just
really
provide
important. Go
let
ahead.
me provide a little context for the audience that when we're talking about adaptive functioning, we're talking about the ability to navigate life. So those are both pretty exciting, and it would be nice to have the convenience of having all of that in one tool. What else do you dream about being able to move into with the research?
Ah, I have a wish list. But
I
I
figured
think
you would.
one of the things that's really important as a next step for us is to understand. So we know that both the FASD tree and Brain Online can identify over 80% of the populations of people that we've tested
Mhm.
who have an FASD or who've been exposed to alcohol prenatally. But one of the things that you're probably aware of is that we see high rates of ADHD, for example, in people with an FASD.
Yeah.
And so one of the things I'm really interested in is, can we tell the difference between people who have prenatal alcohol exposure and maybe ADHD also, and
Mhm.
people who have ADHD but without prenatal alcohol exposure. And so historically, we've have a number of studies looking at that, and we have been able to, there are some things where there's a lot of overlap between ADHD and FASD, and there's some things that overlap less.
Mhm.
But it would be really great if we could use the data that we've collected from Brain Online, for example, and maybe the tree also, and see if we can tell if there's a different profile of functioning between a person who has ADHD who does not have prenatal alcohol exposure. We're actually working right now on looking at, so I mentioned the FASD tree. Part of the FASD tree is a risk score, which ranges from 0 to 5. And the higher the score, the higher the risk that the person had prenatal alcohol exposure. And we're working right now on a study where we're looking at whether we can use the same measures with a different algorithm to say this person is affected in a way that's consistent with ADHD, but not FASD.
Okay.
And this person is affected in a way that's consistent with FASD and may or may not have ADHD. We know the rates of ADHD are very, very high, but we want to be able, so in the real world, if a kid comes into a clinic and is having behavioral concerns and is impulsive and hyperactive, we want the clinician to be able to tell the difference.
Yeah.
And it's hard. And so we want to provide some tools that that clinicians can put into their testing, repertoire that they can use to distinguish between a person with FASD and a person with FASD who may also have ADHD and a person with ADHD who does not have prenatal alcohol exposure.
And that would be very helpful. I I think in part also with ADHD, women tend to be diagnosed much later in life because they miss it a lot in girls.
Mm-hmm.
Because the presentation is different in girls than boys.
Mm-hmm.
So often, and even, I had to chuckle because I first became aware of adult diagnosis of ADHD just through reading all the posts on LinkedIn and getting into those circles there. And I'm thinking, I started to entertain the idea. So when my self-identification of FASD was confirmed, the person who did the test was not qualified to diagnose ADHD, but she kind of nodded like, yeah, you probably, I just can't officially say yes. I mentioned that to a former coworker and she just busted guts. She was laughing so hard. She goes, I've known you had that since I first met you 7 years ago. There's so many reasons why those of us with FASD may present that way. Aside from the difficulties in actually maintaining attention, it could be the need for hypervigilance because of trauma history. That could get it going a lot. So, I mean, there's a lot of things that play into that.
Right, right. And I think it's important for the individual and the clinician to be able to tell those things apart.
And I think part of it too is that I remember when I was first trained facets, the unofficial guidance was that, looking at differential diagnosis and all the overlapping characteristics of FASD with this, that, and the other comorbid conditions, is that if you responded to environmental changes, then you don't have ADHD. And that may or may not be true because in all the ADHD research for a long time, they weren't screening people out for the presence of FASD. So it skewed the data.
Yeah, absolutely.
What else is on your wish list?
I think that's a big one. I think, we recently translated Brain Online into Spanish. So we're going to be trying to work on that. So that's exciting. I think bringing some of the tools together with other types of research. So for example, can we use Brain Online in intervention studies? It would be ideal really for testing if there were new medications that came down the pike. Could we could, it's really, we didn't set it up that way on purpose, but it is designed in a way that could be used to test the efficiency or effectiveness rather of any sort of interventions. So that would be an exciting thing to see. And yeah.
So that would mean taking it periodically to measure for improvement.
Okay. Yeah, absolutely.
That could be a very important use tool. Yeah, awesome. So I wanted to ask a little bit more about the the determination of exposure. So many of the children I saw when I was a foster and adoption social worker, there was no known history or no way of, in the case of adopted children, there's the lack of access to that information. Social workers always send health questionnaires out to birth parents, but they get a minuscule amount of return that requested information. Very few parents, send them back.
Yeah, absolutely. And it's one of the issues I think in our field that is still, well, there's lots of challenges, but it is really challenging in terms of obtaining histories of prenatal alcohol exposure. And I should have mentioned this on my wish list. And that is, well, of course, a perfect screening tool, perfect screening for prenatal alcohol exposure. But really, can we use these tools? Will they be strong enough to tell us in a person where we think there might be prenatal alcohol exposure, is our tool specific enough to tell us that, yes, we do think this person has a history of prenatal alcohol exposure? So, going down the ADHD route is one way to tackle that question of specificity. But if we can show that the results of our measures are specific to an FASD, then we're moving in that direction. We're not there yet. But I do think that there are other ways of screening for prenatal alcohol exposure that could help us. I am in full agreement with what you said. There's often cases where we just don't know, right? And we'll never know. Right. And historically, in our research studies, we excluded people who had that's what their report was. And we actually don't do that anymore. In our study, I'm not speaking for all research, but in our studies, we enroll people who suspect that there was prenatal alcohol exposure, because ultimately we want to be able to compare that group of people with suspected exposure to people where we're pretty sure. But the other thing is that maybe one day we'll have a biomarker, right? Like, there's a study looking at baby teeth. Can we test baby teeth for prenatal
alcohol? I got
alcohol
so
exposure?
excited when I read that study by Dr. Jones.
Yep. So, maybe that's going to be the way.
And then I got very angry. Why isn't this being done at every pediatric dentist across the country?
Yeah.
And then I had to remind myself, slow your roll. It was one study with a small number of participants and application.
Right.
Cool your jets, Patti.
Yeah. I mean, and it is really exciting, and I am hopeful that it's going to, give us an answer. But at the same time, it has limitations too, right? Like, so if a child is in foster care who is 9 or 10 years old, or, older, we're not going to have baby teeth from those kids, right? So, or an adult, right?
Right.
You might have a jar of little baby teeth, but you don't know if they're yours, right? Or they, your siblings, or like, I know don't tell my kids, but I've got a little jar of baby teeth and they're all mixed together. So, but I do think we might get closer to a screening tool like that.
When I was researching about a year ago to get the second edition of my book out, I came across a study that said in cord blood, umbilical cord, or not the blood, in umbilical cord tissue, alcohol stays there for 20 weeks because there's no mechanism within the cord to metabolize it. That's 4 months. So I'm envisioning that should be routinely done at the time of delivery. You get a sample of the cord, you send it off. It's routine to do drug testing. Why should it not also be routine for alcohol testing?
Yeah, Patti, I think I'm not familiar with that study, but I will say that it could also be routine to just ask.
Yeah.
And so,
in a way that's not going to put the moms on the defense.
Right. And
you didn't drink, did you?
Yeah, right, exactly. The way I think about it, Patti, is if we ask everybody, if every obstetrician and every pediatrician and every psychiatrist and every physician, every psychologist asks about prenatal alcohol exposure from every single one of their patients, that goes a long way to reduce the stigma. We're not only asking people that somehow we think, oh, you look in some way like you're drinking or your mother drank.
You're a closet alcoholic, aren't you?
Yeah. So we're asking, if we ask everybody, we're able to reduce the stigma and get more information. And, if you're right, like I said, if you're only asking the people that you're suspicious of, then, you're not, it's only half the job, right?
Right. And truly, I mean, at the time of delivery, women usually confirm only what they know they're going to test positive for, and alcohol is legal. And so why would they pile on extra shame unnecessarily? And I totally get that. So I think it's so important for providers to recognize the way that they use language. And we are getting better at doing that. At routine doctor's visits that are asking about things like poverty and stress levels and safety and emotional safety. And it could be added into even that tool in a way. What was life like for you in the couple months before you realized you were pregnant?
Yeah,
when you were stressed out during that time, what did you do to calm down? Or to find your balance?
Right. Our words and the way we speak are very powerful.
Yeah.
And I do think it's important to recognize that there are ways of speaking and ways of asking questions that are less stigmatizing. Yeah. But I think that screening for prenatal alcohol exposure needs to be part of all healthcare screening. And that's, going to be a big step towards reducing that stigma. If medical students are trained and psychologists are trained, and goes a long way towards reducing that stigma around the prenatal alcohol exposure.
Yeah, and I think my wish list would also include that the training include the reality that this is a neurological condition, and psychological methods are not necessarily going to be effective because it's not a matter of willpower or motivation or choice as it is reflexes.
I guess as a psychologist, I do think that motivation and behavior is important. That there has to be a combined approach, right?
Yeah, but sticker charts aren't going to cut it when it comes to behavior change with FASD. So that's my background as well, psychology. So I'm not throwing psychology under the bus by any stretch of the means.
That's good.
But we're all evolving. All of our fields are evolving, thank goodness. So none of us knew what we didn't know until we learned it. So yeah, I'm so glad you came onto the program.
Yeah, thanks for having me.
I do want to post the link for the Brain Online. And so just to recap our discussion on that, if people suspect or want to know, how likely is it that I may have FASD, or my child or my neighbor, they can pass the episode on to them or whatever. But then people can take the link and then they'll hear back from
yes. If they request feedback, they'll definitely get feedback from us. I should clarify that we won't say what the likelihood is that you have an FASD, but we will say that we think that you would benefit from additional testing. And then you can take that information for yourself or your child to your pediatrician or other healthcare provider, who can then because remember, it's a screening tool, right? Not a diagnostic tool.
Right.
So I think that's an important thing. But absolutely, I will send you the link and you can put it in the description. And, we also welcome people who don't have prenatal alcohol exposure who want to take the test. Like, for example, a parent might want to see what the test is about before their child takes it. And we welcome that. You don't
Okay.
have to have prenatal alcohol exposure to take Brain Online. And in fact,
Mhm.
we need people who don't. So if you have other children who don't have prenatal alcohol exposure, we welcome you having them participate as well.
Yeah. Yeah, that would be fascinating to see those results. I'd love to have you back again sometime, so you can share some of your findings. What's the next point where you're going to be looking back and tabulating results? And
That's a good question. We do that all the time. And so I think I mentioned one of the things we're working on right now is whether we can improve our FASD tree to address this ADHD question. Another big decision point, well, we're trying to seek additional funding for our Brain Online in Espanol, so our Spanish translation, and then additional funding for our specificity question. So how can we show that Brain Online is, really specific to FASD? That's going to be another big thing that we work on.
What about looking to see if it could be used in the differential diagnosis between FASD and autism?
Yeah, that's another big area. And I think that in my view of the sort of, for my part of FASD research, it's that specificity question, right? So autism or autism spectrum, ADHD, other developmental conditions. I'm definitely, that's my lane, right? And so that's definitely the direction we'll be going in.
Because those are the two diagnoses that we are most often misdiagnosed with,
Right.
and you could have all three.
Absolutely. Yeah, I like to say that it's not necessarily a misdiagnosis, right?
It could be a partial
right.
diagnosis.
Right. I mean, I have
Because
this
it's not either
conversation.
and, it could be both.
Right.
Or
I
it's
have
not
this
an either
conversation.
or, it could be this and that.
Right. Absolutely. I have this conversation with my students a lot when we talk about diagnosis and screening of FASD, and we often, talk about misdiagnosis, but really, we're not saying that you don't have not you, but the world don't have ADHD. You might have ADHD, but we think that FASD is the most parsimonious explanation for those conditions, right? So I don't think of it as a misdiagnosis. It's just we need to understand the full diagnostic spectrum.
Okay, wonderful. Well, thank you so much for joining us this week. And I can't wait to get this information out there to everybody.
Yeah, thanks, Patti.
Thank you for joining me for this episode of Living with FASD, Candid Conversations with Patti Kasper. Feel free to send comments, questions, and topics you'd like to learn more about, hear more about, to me at livingwithfasdpodcast@gmail.com. Please remember to like, follow, and share this podcast on whatever platform you use so that more people can find the podcast. Have a blessed week, everyone, and tune in next Monday for another candid conversation on Living with FASD.